an hour after your lunchtime. Don't forget to chat in your hospital name or organization, and I'm sure some more people will be trickling in. So this is our third SMM webinar, and our goal is to have these quarterly. So just whenever you get a moment, if you just don't care to chat in your hospital name, organization, and your role. Our agenda for today. Welcome and introductions for me. Megan Young will review over the major OB committee. Doctors Nelson and Wolf will then review some SMM cases, and then we'll just have our closing. Today we have our friends over at UT Medical Center in Knoxville joining us. Dr. Nelson is the medical director at UT. He is board certified in both obstetrics and gynecology and maternal fetal medicine. Dr. Wolf is an associate professor, and she is also board certified in both obstetrics and gynecology and maternal fetal medicine. And Megan Young, who is the manager of quality improvement and process review. So thank you all for joining us today. All right, and first up, we will start with Megan Young.
Hello, thank you for having us. So I serve, as Tanika said, the manager of quality improvement and process review. So I'm a non-clinical person behind the scenes helping our clinicians implement evidence-based practice and evaluate where we are. I also serve as our co-chair of our major OB complications committee, and I'm going to talk to you a little bit about how we developed that committee, where we started, where we are now, and some of our key areas of focus. Next slide, or do I have control? Oh, there we are. All right, so we began our journey in April of 2021. We knew we wanted a committee to review complications. We had a lot of passion for it and a lot of discussion across different committees expressing the need. In our first meeting, we had 9 members in attendance. So we had 2 nurse managers, 2 nurse educators, 1 clinical nurse specialist, a general OB, an MFM, myself, and a chaplain. And we first sat down and said, all right, who else needs to be here? What is our purpose? What should our process be? And we asked a lot of questions, and those questions continued throughout the rest of 2021 as we kind of firmed up what we were going to look like. So fast forward, we had developed a purpose, which was to improve quality and patient safety by identifying the process and expectation for managing major obstetrical complications across our antepartum, labor and delivery, and postpartum settings, and make sure that there were resources available for patients, staff, and family members affected by complications. We knew we needed to identify data and which cases we should review. So we decided to pull data monthly across a couple different formats. So every month I get a report of ICD-10 codes for all severe maternal morbidity conditions. I also get a report of babies who were either diagnosed with HIE or experienced cooling. And then I also get a separate report on any patient who came from one of our maternal units and went to the ICU. I guess that should say ICU instead of ICD, but you'll forgive me. And then I get a report of lab values for all neonates with a cord pH less than 7. I also get a incident report or sometimes word of mouth on situations that are deemed reportable by staff members because they were either traumatic or they felt like there was an opportunity to improve. So we've got a pretty good culture of passing these along to make sure that they get reviewed and we can improve our systems. So after I merge all of these reports into figuring out what cases we're going to review each month, I assign them to a nurse and a provider to review. We have decided that this is the best practice because sometimes providers can pick out things that are missing in provider documentation, and likewise, nurses can pick out things that are missing in workflow or documentation that are standards for nursing. And so it takes really both lenses and perspectives to be able to accurately identify areas of success and opportunities for improvement. Next slide. Right, so where we are today, we currently meet monthly. We have an in-person preferred, but also virtual option since some of our clinicians wrap up clinic and are across town or are stuck on labor and delivery. Our meetings are 1 hour, and we have found 5 p.m. to be the sweet spot. We have the best attendance at 5 p.m. 4:30 was a little bit too early for clinicians to make it after clinic. Our general structure in that hour is about 30 minutes for case reviews and then 30 minutes for discussion. Now that's obviously not possible all the time when you have really robust case reviews and discussion, and there's natural discussions that happen during case reviews and back and forth. And though 30 minutes would be ideal from my standpoint of managing the meeting and making sure we get to everything, sometimes we do have to review cases for 50 minutes because there's a lot going on or there's really robust conversation that happens throughout those case reviews. All members on this committee are volunteers and pretty excited to be there, even though some of the conversation can be pretty heavy. It is a pretty fun committee and a lot of quality improvement comes out of it. So it's definitely really rewarding. We also have created our structure where we will add subcommittees as needed. So when we have identified a pattern of hypertension readmissions, we created a subcommittee just to look at that topic. We also have a hemorrhage subcommittee just to look at hemorrhages and ways to decrease those. And then we have a zero harm subcommittee that picks a topic and works on that for the year. Those subcommittees sometimes meet every month, and then sometimes they meet as needed, just based on what our data is showing. And then the ideas and strategies that the Major OB Complications Committee comes up with get presented to our broader Women and Infants PI Committee so that fresh eyes can look at what we've come up with, give feedback, think about it in their settings or clinics, and then approve it for it to actually be in effect. Next slide. Right, so today we have 48 members on our committee. So it's definitely grown over time, and it's a really fun committee, like I said, to be a part of. So we do have a lot of committee members who review cases, and then we have some that don't and are there to provide their perspective. So I put a little asterisk next to the folks that do get case assignments. I do track how many case assignments each person gets to try to keep it equal across the year. So we try to have at least one OB provider from each practice, including our midwives, MFMs, our OB residents. I think we have 4 of them currently on the committee. All of our MFM fellows are on the committee. We have neonatology, really one representative, and then we pull in the medical director as needed from neonatology. And then all of our nurse managers, educators, our OB team lead is on that committee. We have our regional perinatal educators so that they can go out into the region and speak about how we are implementing or addressing a certain topic, and it really helps, break down the silos there. We have staff nurses who have elected to be a part of the committee and provide their perspective of, okay, maybe this complication occurred, and well, consistently at this time of the day, we face XYZ. It's really good to have that perspective as well. Our quality improvement personnel, I pre-screen cases to make sure that they meet criteria of the committee, and then usually get our chair to give final approval if I have any questions. But then I do have a data specialist nurse who helps screen the hemorrhage cases. So there's some quality review that we do as well. We have case management, pastoral care, and IT analysts. IT analysts have been a newer addition to our committee in this past year, and that's been really exciting because we might have an idea on how to better document or track something, and they're right there in the moment to be able to provide feedback on that. And then, of course, we have executive level leadership. We have our vice president, executive director, our medical director, Dr. Nelson, that you'll hear from in a moment, and he too gets case assignments. So we do definitely share the love across levels of providers. Next slide. All right. So some of our keys for success. All voices matter on this committee. So we make sure it's in our charter. All committee members have an equal voice and a say in decision making and feedback. And when we have really adopted this culture in our committee, it's been super fun to have people be able to speak freely about different barriers and things that they've encountered so that we can really get to the heart of an issue and effectively have change. Another key for success is to keep it brief. So Doctors Nelson and Wolf are going to go into more depth of a actual case review, but I did want to take a little snapshot of what our Excel file that we look at for each meeting looks like. So as you can see, we've got our complication type, our maternal, neonatal MRNs, race, ethnicity, reason for admission, delivery route, time and date, gestation, G's and P's, and then our investigator findings. And this is where I try to have everything filled out as much as I can, except for the investigator findings. And that's where some of our clinicians can write quite a bit, and we can definitely get lost in the weeds of extensive history of patients that really isn't relevant to the particular complication that occurred. I'm sorry if you can hear the announcement behind me. It's a little distracting to me at the moment. And then the reviewers will then go in and write successes that they identified, opportunities, and we always ask for a review of any health equity notes that may occur. So were there any social determinants of health or language barriers? Was poverty a barrier to getting to care earlier or following up to care? And so in the next slide, I'll show you how you can see that when it's filled in, it can be pretty busy. So what the committee unfortunately gets the privilege of doing is listening to me read the clinical summary so that we can get through it quickly, and then they will then share the successes and opportunities for improvement and health equity notes. And we have found that keeps it really brief so that we can focus on those key areas and we're not getting lost in the weeds of the patient's background and history. Next slide. All right, so we also want to make sure that we keep it kind. And so I'm not a sports person, but I know there's a reference about quarterbacks and them occurring on Monday mornings. So I put that in there, but I wanted to give you two examples of how you can keep it kind during your case reviews. So some comments that are not helpful are, I would have ordered that test on admission, whether it be a FAST exam, a vaginal ultrasound, postpartum. These are two examples that we found in our time as a committee, and some alternatives to that phrasing could be, what were the barriers present? So maybe staff didn't have all the information they needed at admission, or they didn't have the skills and understanding. And so one example of that is we identified that our residents and fellows needed FAST exam training. So we were able to get that done and be able to help them be better equipped for the next time. And pretty soon after they were trained, they had to implement and use that skill. Another alternative would be, uh, you know, the team could consider this test in the presence of this condition, or there's an opportunity for department-wide training. Another example is for postpartum patients, we were finding that our ultrasonographers were a little hesitant to use vaginal ultrasounds because they were worried that it was going to cause an infection. So we did department-wide training with their department to ease them and really promote vaginal ultrasounds when that is ordered and looking for retained products. Next slide. Another comment that might not be helpful is they should have proceeded with an intervention sooner. So that examples from our committee were supplemental oxygen or cesarean delivery. Alternatives to that phrasing could be, is there more context needed? So maybe a patient was refusing an intervention or refusing, cesarean delivery. Maybe we need to document why that patient had fears about their cesarean so that it, one, covers the provider providing the care, but then also provides more context to those providing care postpartum. Another thing to consider is health literacy. So do patients understand why they need supplemental oxygen, and what can we do to better communicate that next time? Next slide. Another key for success is fostering introspection. It can be really hard to look at ourselves and think about what could we do better. But some examples could be, how can I help to make the system better so individuals can do their job well? How can I be an example of culture change? How can I better understand the workflow of other disciplines? How can I support better communication? Why is that our process, and what should our standard be? And I really do feel our committee members try to take this lens instead of playing the blame game. They really do introspect, have some introspection to help make sure that we can do better for everybody. Next slide. All right, so this is a little bit of a busy slide, but another key for success could be to find your chairs. So Dr. Reeder, one of our MFMs, is the chair of our committee. And then as I mentioned earlier, I'm the co-chair. And so we often act as mediators between disciplines. So if you'll go with me for a second, on the top left, we provide neutral generation of process improvement ideas and maybe recommendations from candid feedback that we got from committee members or team members. And sometimes we get pretty candid things and we don't share who said what, and that's really helpful. It's just good to get sometimes an unfiltered perspective, and then we can filter it out and provide a neutral recommendation. And then likewise, we can provide recommendations to the department on behalf of the committee, and they can then come back to us and give us feedback on how that's either going or perceived. And we also engage other disciplines. So we work with anesthesia, lactation, NICU to make sure that everyone feels engaged in whatever we come up with as a committee. And we also work to share PI strategies outside of not only the committee and our department, but also our institution. So that is a lot of fun and an avenue that we're growing in. Next slide. Another key for success is communicating recommendations. So pretty early on, we found that everyone on the committee was aware of what needed to change, but we needed to do a better job of communicating that outside of the committee. So in order to break down silos, we came up with a standard communication form. So every time, not every month, but most months after a meeting, we'll, jot down key areas for improvement department wide, and this is an example of one. So we found an opportunity for improved documentation of interpreter services that are being utilized for patients who are non-English speaking. And our recommendation is that any basic conversations like where's the bathroom or what flavor popsicle do you want does not require the use of interpreter services. But outside of those basic conversations, interpreter services should be utilized, especially when documenting consent or obtaining consent from the patient for a procedure or intervention. And so we gave some examples of what it looks like to document in-person interpretation or interpretation provided via our electronic CIRCOM. Next slide. And then if you're wondering where to start, here's a few ideas. So you can pull your severe maternal morbidity data and look for opportunities at a systems level for improvement. You could evaluate your readmissions or surgical sites infections to see what your trends are. You could perform a survey. We performed a survey that asked these questions below, or asked people to provide feedback on these statements. And it provided so much feedback that we worked on improvement and addressing different things for about a year and a half. So these questions alone can definitely help you. So understanding the perceptions of providers giving respect to nurses and nurses receiving respect, the most common reasons a provider either needs to be paged or is paged, contacted, the most frustrating reasons. So a lot of those have to deal with things that could be part of a pathway or bundle that's already in existence. The reasons that, or the requests for orders that you wish were part of an existing pathway, and then other things that you wish you could change about communication. If you're looking for a place to start, these questions really highlighted a lot of ways for us to improve. Next slide. Okay, and so I think I only have 2 more slides. But our recent areas of focus have included earlier actions for hemorrhage and really promoting stage 0 hemorrhage, so not even getting to a hemorrhage, supporting breast milk feeding when there's maternal ICU admission, improving communication between outpatient and inpatient services when it comes to special care babies, decreasing readmissions for hypertensive disorders, improving communication of cesarean urgency across nursing, OB, and anesthesia disciplines, focusing on community partnerships. So one of our partnerships is with Centro Hispano, and we've been learning a lot about how our Hispanic patients are perceiving the care that they get. Documentation standards kind of comes up over and over for different things. Prophylactic aspirin recommendations in the prenatal care setting, antibiotic redosing after stage 3 blood loss in a cesarean, and then communication strategies in the setting of a category 2 tracing. So we've had many more, but those are the current ones. Next slide. Great. Thank you so much.
Thank you so much, Megan. I think you have a few questions in the chat as well.
Oh, I'll get to those while you go to the next presenter.
Thank you so much. And next up, Doctors Wolf and Nelson are going to review some of their case presentations for us.
Perfect. So my name is Trip Nelson. I'm one of the maternal fetal medicine docs here at UT Medical Center, and I appreciate the invitation to speak and review a case. I'd also like to give a big shout out to Megan Young, who has done instrumental things for our department in all things PI and QI, and our OB complications committee is a great example of that. So hopefully that generates question and interest across the state. I'll go ahead and review a case of substance use disorder with sepsis, and then Dr. Wolf will take over and review 2 additional cases if we've got time. So next slide. So this first case is a 41-year-old G6P5 who presented to an outside institution with pretty vague complaints: fever, chills, sweats, body aches, some diarrhea. She'd noticed some decreased urine output and some lower extremity swelling over the last several days, and some upper arm swelling after an altercation with her partner. She had a productive cough of green and brown phlegm. She also gave information that she has a substance use disorder and is currently having symptoms of withdrawal from heroin with the last use of opiates approximately 3 days ago. So she was transferred from an outlying institution to our ER, and at the time of her transfer, she was found to be about 22 weeks gestation by bedside ultrasound with no prior prenatal care. Next slide. So her initial evaluation in our emergency department had a temperature of 97 degrees, was mildly tachycardic at 101, respiratory rate was 17, blood pressure was noted to be low at 94 over 48, but was satting normally. I think this is a great plug for sepsis patients. They don't always have fevers. They're not always severely tachycardic, and always those things should be taken into consideration when evaluating patients. Obviously, given her blood pressure, she was noted to be in septic shock. She was very ill appearing and generally cachectic. She initially responded well to fluids in the emergency department and was given approximately a 3-liter bolus, but subsequently required vasopressor support with Levophed. She was essentially underwent a CT chest, abdomen, and pelvis, and was noted to initially have a foreign body in her vagina on the CT scan. But by the time the ED physician got that read and performed a physical exam, no foreign body was noted. Labs in the emergency department were significant for a dramatic increase in her creatinine at 5.64, concerning for possible either acute kidney injury or acute on chronic kidney injury, given her lack of kind of baseline available labs. She had metabolic acidosis and an elevated anion gap of 26 and a markedly elevated beta natriuretic peptide at 7513. Evaluation of her electrolytes, she had hyponatremia with a sodium of 129, hypokalemia with a potassium of 3.3, and a what I would call low white blood cell count of 5.6, considering her overall clinical picture. She underwent multiple imaging modalities, including a renal ultrasound with just mild hydronephrosis on the right, but no evidence of obstructive renal etiology. She had an upper extremity X-ray. Given the history of recent altercation, it was not noted to have evidence of fracture or any other osteomyelitis. Next slide. She underwent CT chest imaging, as I mentioned, and was not found to have evidence of pulmonary embolism, but had a multifocal consolidation with ground glass opacities, mostly in the right upper and lower lobes. This is a screenshot of part of that chest CT, which demonstrates that multifocal consolidation and ground glass opacities there kind of in the posterior region on the right side. That chest CT also evaluated and demonstrated multiple hypoattenuating wedge-shaped splenic foci consistent with splenic infarcts, likely secondary to septic pulmonary emboli or septic splenic emboli. She had a head CT, which thank goodness for her was negative for intracranial embolism, and had bilateral lower extremity Dopplers that were negative for deep vein thrombosis. Next slide. So she was rapidly transferred to the ICU given vasopressor management and her otherwise clinical illness. She was aggressively treated with IV fluids to help maintain her blood pressure. In addition to vasopressor support, blood cultures were obtained, and she was immediately started on broad spectrum antibiotics with vancomycin and Zosyn. Her Levophed was titrated to maintain a MAP of greater than 65. She initially underwent a transthoracic echocardiogram, which demonstrated normal systolic and diastolic function and a fairly normal ejection fraction. She had no wall motion abnormalities, and no valvular abnormalities were noted at that time. But after consultation with infectious disease, as well as further deterioration in the clinical status, the patient underwent a transesophageal echo that demonstrated a small vegetation for mass that was noted on her aortic valve, and given her clinical history was presumed to likely be infective endocarditis. She got a consultation with CT surgery at that time, and given no evidence of valvular dysfunction and no other evidence of underlying cardiac dysfunction, their recommendation was for continued medical support and antibiotic therapy. She initially also was noted to have significant symptoms of opiate withdrawal, and given her critical illness was initially managed with IV opiate and oral opiate medications as needed, in addition to being given supportive care for diarrhea and nausea and vomiting and those sorts of things. As I mentioned before, she had a renal ultrasound given concern for significant acute kidney injury, as well as a workup with serum and urine osmolality and ongoing evaluation twice daily of her electrolytes. And nephrology was consulted once she arrived at the ICU to evaluate her for possible need for renal replacement therapy. Next slide. Unfortunately, her blood cultures confirmed Staph aureus bacteremia, and so in consultation with the ID, her antibiotics were narrowed initially to oxacillin. She had viral respiratory panel that returned negative for COVID or influenza, and hemodynamic improvement was initially noted with antibiotics and IV fluids, and she was able to be weaned on her Levophed, but ultimately her acute kidney injury continued to progress with a rising creatinine that you see there. VUMEX was initially initiated by nephrology with labs, as I mentioned, twice a daily and very close monitoring for urine output, which remained very scant over the course of the next day or two. As mentioned, we gave her supportive care initially for her opiate use disorder and withdrawal symptoms. And initially, she was thought to be nearing the ability to transfer out of the ICU after approximately 48 hours. But unfortunately, as you'll see in the next slide, her acute care progressed. So she was noted to have an increasing O2 requirement on day 2 to 3, which ultimately resulted in hypoxic respiratory failure, presumably due to volume overload with her minimal urine output and pulmonary edema. And ultimately, she did require intubation and mechanical ventilation and was sedated. Next slide. So at that point in time, given her periviable gestational age, we convened a multidisciplinary meeting, which included many of the teams that were participating in her care to discuss desires for pregnancy management. At our institution, we typically offer resuscitation after 23 weeks, but we'll have a case-by-case discussion between 22 to 23 weeks. So ethics was involved as well as the ICU team, our OB team, and maternal fetal medicine. Case management, both from the ICU as well as from the OB team, were also present, as well as our NICU colleagues and psychiatry. We were able to identify a family member and an aunt who could establish decision-making, and overall her maternal condition were reviewed, and a decision was made to consider her pregnancy non-viable at that point, given the overall maternal critical illness and the potential that surgical intervention could dramatically worsen her overall medical state and increase her potential for maternal mortality at that point. Next slide. So given her ongoing oliguria and an uptrending in her creatinine to 8.1, as well as concern for volume overload, nephrology consulted our vascular surgery colleagues, and a VAS cath was placed, and she was instituted on hemodialysis on hospital day number 3. She was given a total of 5 dialysation treatments, but ultimately was extubated 24 hours after the first treatment due to her improved respiratory and volume status. Her creatinine was noted to trend down dramatically after 3 days of hemodialysis. Unfortunately, her blood cultures were persistently positive for gram-positive cocci clusters, and so her antibiotic regimen was broadened to ertapenem by ID on hospital day number 4. However, given the marked improvement in her overall mental status, the ability to wean her, sedation, and ultimately extubate her, we were able to involve our psychiatry colleagues and were able to transition her to buprenorphine microdosing to assist with her withdrawal symptoms and to hopefully stabilize her from an opiate use disorder standpoint. This team, which is part of our CARES team, which we'll get into a little bit later, which participates in our pregnancy and recovery clinic, also began to work on inpatient rehabilitation for the longer term, with hopes that eventually, if we were able to stabilize her and get her to a point of discharge, that we would already have things in the work to get her into a long-term stabilization program. Next slide. She ultimately required an 8-day ICU course to stabilize her enough so that she could be transferred to the floor. She, at that point in time, was able to participate in more multidisciplinary review in terms of considering pregnancy viability, and we initiated fetal monitoring as well as betamethasone for fetal lung maturity at approximately 24 weeks. ID ultimately recommended that she undergo 4 weeks of IV antibiotic therapy, and given that she had a history of opiate use and substance use disorder, it was deemed that this needed to continue as an inpatient basis. She developed some vague obstetric complaints of intermittent spotting, but had no consistent evidence of ongoing abruption or preterm labor. But as we were able to gain more formal ultrasound evaluation once she was out of the ICU, she was noted to have fetal growth restriction, along with oligohydramnios that range from an AFI of 2 to 5, depending on the day. And our concern was for PPROM versus chronic abruption, but she was already undergoing broad spectrum IV antibiotic therapy, which was deemed appropriate coverage for both her bacteremia, endocarditis, and potential PPROM. She never developed consistent symptoms at this point in her hospital stay of loss of fluid or increased discharge. Next slide. She ultimately completed a month of IV antibiotic therapy on our inpatient service and underwent continued monitoring for oligohydramnios, possible PPROM, and did very well from a standpoint of opiate use disorder and stabilized on buprenorphine replacement therapy. I think it's important to acknowledge the complex social situations that many of these patients will have, especially during long-term hospitalization. And ultimately on hospital day number 44, she alerted our team that while she had reported intermittent homelessness, all of the possessions that she had in this world were residing in her partner's apartment, and that he was currently being evicted for mold infestation, and that she had to leave at that point in time, or that she would lose all of these worldly possessions. So ultimately, she signed herself out of the hospital against medical advice, but promised to return once she was able to stabilize her social situation, and did in fact come back to our institution 2 days later for readmission. However, now she was developing symptoms more consistent with PPROM and had persistent clear vaginal discharge. After ruling her in for PPROM, latency antibiotics were initiated since she was not on further antibiotic therapy at that point after a division discussion within our maternal fetal medicine group. Next slide. 4 days following her readmission at approximately 28 weeks, she alerted our OB team at almost 11 p.m. that she was having cramping and felt increased pelvic pressure. And unfortunately, an umbilical cord prolapse was noted by our team on examination. Due to that and malpresentation, she was brought down emergently and underwent a classical cesarean delivery. APGARs were 4 and 7, and you see the birth weight there at 1,360 grams. Next slide. Her postpartum course, unfortunately, was complicated by postpartum endometritis, requiring additional antibiotic courses. She underwent multimodal pain management following her cesarean section to minimize narcotic use, and was continued on her buprenorphine replacement therapy. She underwent co-management with psychiatry and what we have dubbed our compassionate access to recovery support, or our CARES team that works within our pregnancy and recovery clinic. She did well long-term on buprenorphine replacement therapy and ultimately was able to be discharged after a total hospital course of 58 days. Her neonate remains in our NICU, but I am happy to report has done very well, has not developed any evidence on imaging of intracranial hemorrhage, and is on room air at this point. Next slide. Or next slide. I am happy to report to this group that the patient was discharged and in stable housing, and ultimately did follow up as of this morning with our pregnancy and recovering clinic, and is doing very well in remission from opiate use disorder. I felt like it's very helpful to review some of the more recent maternity maternal mortality statistics that came out in the most recent 2024 bulletin from the Tennessee Department of Health. Overdose deaths have increased from 20% to 34% across our state. And this is at the same time that we've noted a decline in maternal mortality, and that now maternal mental health conditions are the leading cause of pregnancy-related mortality, accounting for up to 28% of deaths, and that substance use disorder accounted for 70% of these deaths due to maternal health conditions. I think it is a big plug in our state, especially when you consider this case. And I thought about reviewing care of sepsis in pregnancy, and I feel like that's something that many of us are familiar with and is important. But the long-term care that's required on the inpatient side could likely be deferred in many situations if we had improved access to care on the outpatient setting in terms of both maternal mental health support as well as support for substance use disorders that can occur in our pregnant population. Next slide. I also think it's important to point out the strong association between substance use disorder as well as mental health disorders. And what is brought forth in this most recent annual report is that 30% of maternal related deaths had both substance use disorder and mental health conditions that were discerned by the MMR committee to be contributing factors to their deaths. Next slide. So I'm going to step out of the way and let Dr. Wolf present, and I'm happy to take questions from anybody either through the chat or at the end of the presentation.
Okay, so this next case is something that can happen anywhere at any hospital, so we chose to present it here. So it's a transfusion reaction versus AFE. Next slide. Okay, so this is a 34-year-old Gravida 1 who came in for induction of labor at 38 weeks and 6 days. She had severe polyhydramnios that had been followed as an outpatient, and it had increased to 37 centimeters, and so she was sent down for induction. She had limited and late prenatal care. She had been incarcerated earlier in pregnancy. She reported she knew she was pregnant, but just had substance use disorder, and for that reason had not sought care until she was incarcerated, at which time they brought her in. In terms of her substance use history, it was mostly methamphetamines. Since being incarcerated, she had been in recovery and had been abstinent since that time. Next slide. She had a notable past medical history for von Willebrand's disease. It had been diagnosed about 10 years prior. She reported that she'd had heavy cycles and she had seen her OBGYN at the time in another city, and that they had told her that she had von Willebrand's and that she should see a hematologist, but she never saw them. When she came to us in that second trimester, around that 28-week time frame, we did, with that history, did get the scheduled labs for von Willebrand factor and risperidone cofactor. They turned out to be normal at that time, and that's expected since those typically will increase in pregnancy. And the third trimester, that we repeated her labs, and unlike the 8th, and I think she goes into induction on the 18th. So at that time, the day, checking like the day prior to induction, I remember seeing her in the office. Her labs weren't back yet, but we weren't overly worried because, again, as expected, those labs are generally elevated in pregnancy, and so we just said, go on with your scheduled induction. We'll follow them up when they get back. We had made a referral during her hospitalization to hematology, but again, she still lived about an hour away from us, and she claims she didn't know about the appointment, although we remember telling her. So I think a lot of it had to do with multiple barriers to her getting into that office appointment, but nonetheless, she missed her heme appointment during the pregnancy. Next slide. So she came in at midnight because that's when she was scheduled for her induction. And thankfully, I think she was noted to be in transverse presentation. So since it was midnight and they talked to her about would she want a version or would she want an elective C-section, she wasn't NPO for a C-section. She had opted for a version anyways. So they deferred it to the AM. And since she was there, they were like, well, why don't we just get hematology to see her? That was a plan anyway, to plug her into them and kind of have some follow-up for postpartum. But on that day of admission, the labs that had been drawn 10 days prior actually returned. And very interestingly and surprisingly, they returned abnormal. So when the hematologist did their consult, they were able to dig up the labs from 2014 when she was not pregnant, and indeed did see that von Willebrand factor was low. They noted that the labs that were drawn in the second trimester were, as expected, normal. And then they noted it was unexpected that the labs just prior to her admission had been abnormal. And the von Willebrand factor antigen was 59, risdiplam cofactor were 33. So they acknowledged that those, while those were low, that the PT that had been drawn on admission was actually within normal limits. So for this purposes of this consult and this admission, they said that they did not necessarily expect any excessive bleeding with either a vaginal delivery or a C-section, and they actually did say that neuraxial anesthesia was acceptable, and they ordered repeat labs. So the next morning when they were talking about what her choices, anesthesia actually was like, we don't feel very comfortable with that. They declined to do neuraxial anesthesia. So we then went to the patient and said, hey, you can either have a cesarean section under general anesthesia, or we can attempt an unmedicated version. She chose the version. It was successful. She was noted to be 3 centimeters in the OR, and so they broke water prior to leaving the OR, and that was around 11 a.m. So, next slide. So she, Pitocin was started. She had some recurrent variables off and on throughout the day, which made them titrate up her pit a little slower than ideal. She had only gotten to 11 units, but she was contracting fairly good. And by 11 p.m., she said, I can't tolerate this pain anymore. And she requested cesarean. So just like 1 minute prior to midnight, I think, is when they went in and did delivery. And after delivery, they exteriorized the uterus, and they noted almost immediately some uterine atony. So they started with the typical Pitocin, which is standard. Then they added misoprostol and methergin and 1 gram of TXA. At that moment, or by the time they finished up, they felt like things were getting better. The quantitative blood loss was around 1100. Hysterotomy was closed. Tone was improving. They thought they were doing well, but they were also having a little more bleeding than normal. They were like, let's just, given her history, give her FFP and another gram of TXA because of this von Willebrand. And about the time that they are giving these, which these 2 things were given, the 2nd gram of TXA and the FFP were given very close to each other. The patient had, they said that they noted that the patient had a Valsalva, and then all of a sudden she has profound hypotension, and her saturations dropped. Her blood pressure was like 50s over 30s, and her low 80s is where her O2 was going, and that was on her ventilation. And so anesthesia immediately gives 2 liters of normal saline, and they, of course, have all the meds because they're in the OR, and they start their epinephrine, phenylephrine, as well as vasopressin. So she immediately goes on 3 agents. Next slide. So when we look clearly with that hypotension, she is in some form of shock. So when we are contacting ICU, like I liked the way that they phrased their note, because it was like undifferentiated shock. And then they were like, could it be septic shock? Could it be obstructive shock? And from an obstructive standpoint, they're thinking like, is there bleeding somewhere in the abdomen that is causing compression of something, obstructing something? And then they were like, is it hypovolemic? So in the hypovolemic, could it be from a significant blood loss? Could it be from an AFE, or could it be from anaphylaxis from some blood product, or even TXA? Next slide. So with her acute respiratory failure, she obviously goes to the ICU. Well, she remains intubated out of the OR, goes to the ICU on mechanical ventilation. They're doing the ARDS protocol to keep the pressures low. They continue 3 pressors. They give her, in the event of thinking that might be anaphylaxis, they're doing antihistamines. They start broad spectrum antibiotics with vancomycin to cover for anything that might actually be infection. They get pan cultures to prove that with blood, urine, and the respiratory PCR. They pan scan, and meaning they did a CT scan of the head without contrast, a CT-PE, CT abdomen and pelvis with contrast because they're looking for that obstruction they had mentioned earlier, and they get an echocardiogram, all of which actually return normal. They check labs to rule out DIC, so they got a TEG, a fibrinogen, and then the coag. And they notify the blood bank of this possible transfusion reaction, and they actually give her stress dose steroids while she's on multiple pressors. That's to help prevent any crisis otherwise. Next slide. So she, interesting, like she has her respiratory, well, okay. So on post-op day 1, the highlight of that was that she has this persistent refractory hypotension. She remains intubated and sedated on 2 pressors. They started going through all the things. She wasn't coagulopathic. She was actually ventilating pretty good, so it wasn't the respiratory that was her main issue at this point. It was actually the hypotension. Her blood counts were stable, so it wasn't hypovolemic shock. There was no source of infection. It's not septic. And again, all those pan scans were normal, so they weren't looking at an obstruction. So they're kind of going back and still kind of saying AFE versus anaphylactic reaction. And next slide. On post-op day 2, they were actually able to wean to epinephrine only in the morning, and then by the time rounds were over, they'd actually gotten her off all of the pressors. And then she extubates, and she does well at the end of post-op day 2. So they watch her overnight, and still we don't exactly know what caused it. The ICU, the trauma service was kind of still saying anaphylaxis versus AFE. The obstetric service was saying it didn't really fit the picture of AFE. We felt it was more reaction. So she ends up moving out of the ICU. Antibiotics are discontinued because all cultures were negative. She had a little bit of nausea and concern for post-op ileus, so they were feeding her. They stopped her feeding. She got better on post-op day 4, advanced her diet, and she was able to go home on post-op day 5. So next slide. So she has a couple of SMM indicators. Dr. Nelson's case had like 8 or something crazy SMM indicators, but this one has shock. AFE, it was in the differential, but again, from the obstetric side, it just didn't quite fit the picture, so none of us really thought it. But I mean, there's no way to prove what exactly what occurred. So I mean, I left it in as potentially one of our SMM indicators, and then of course ventilation because of the need for respiratory support. Next slide. Skip this. Go to the next slide. So she had a lot of interesting things in terms of her case in general. She had like limited health literacy, so she didn't have any medical follow-up prior to getting pregnant. She had late prenatal care, which changed things with this pregnancy. Both the incarceration and the substance use can create stigma, which the patient can feel, then the team can also portray. So that could have limited her care. It was kind of a big deal that she lived in a rural setting since she was so far from the hospital, and it was very difficult for her to get places. And then post events, like in terms of long-term follow-up, when she was leaving the hospital, we were trying to portray to her what happened so that she understood the importance of it for future issues. But even with her low health literacy, it was very difficult to know how much that she completely understood and how much that she knows that it was, just not an error in medicine, but something that can just happen. Next slide. So some key takeaways from this case in general is that collaboration is super important. We were in the OR when everything happened, so that really made it made us able to act fast. We had anesthesia right there. They immediately gave fluids, which I think was absolutely important in this case specifically. And then we also had that collaboration with the critical care team, and throughout that whole time, everybody was just openly communicating and going back and forth between what to do and what to treat with. And I think that also lends to good outcomes. The second thing is that early recognition will absolutely save lives, and so will protocols. And that we need to have rapid response systems in place, because while this patient was getting it because we were worried about von Willebrand's, there's plenty of times that we use products from a postpartum hemorrhage on our on the unit all the time. The other thing is we truly didn't know whether this was actually a reaction to her TXA or if it was a reaction to FFP. Everybody leans towards FFP, but we again truly don't know that. And then I also think it's important to debrief with the team, whether it's immediately after the surgery and the event that happened, we debriefed with the anesthesia team that it occurred with the next day when that anesthesia team came back. And I think that was very helpful, because that's where we were all like, it's we think it's truly one of the products, but is it FFP, or it's truly one of the medications? Is it FFP or is it the TXA? So we will, again, never know. But I think the debrief to understand for us is important, so that we know how to process and what we can do better in the future. As Dr. Tate mentioned the first time around, it's not about, what did she say? Something like, it's not about critiquing, it's about learning from it. And so it wasn't about what we could do differently, but it was more about, what would we do in the future, or how can we make things better? So I think we're probably out of time to do the last case. Tanika, do you want me to run through it really fast or no? It's a postpartum hemorrhage case, which we've done before.
Yeah, Dr. Wolf, you guys are more than welcome to run through it, just because I'll keep recording, and then if anyone needs to hop off, they'll be able to come back to it. Okay.
Sounds great. Perfect. Okay, so it's kind of funny. It's Danielle did a postpartum hemorrhage in twins, but this is very different. Next slide. Okay, so this is a 30-year-old gravid 3, pair 0020, who was admitted at 33 weeks with dichorionic diamnionic twins with complaints of elevated blood pressures and concern for decreased fetal movement. She'd had a history of preterm labor in this pregnancy at 30 weeks. She was admitted at that time. She arrested arrested dilation at 3 centimeters. She got steroids, and during that admission got a diagnosis of gestational hypertension. She was readmitted at 32 weeks for vaginal bleeding and contraction pain. At that admission, she was noted to be 5 centimeters, but she remained 5 throughout that hospital stay. She stayed 48 hours and went home, but with a new diagnosis of pre-E without severe features. When she presented back at 33 weeks, this time she'd had some severe range pressures at home, and she had another one in triage. We held on to her for like another several hours, and ultimately she had another one. We gave her a diagnosis of pre-E with severe features, and then planned inpatient admission until delivery at 34 weeks. Next slide. So it's important to know her past medical history. She'd had 2 SABs, but never a DNC. In 2023, with the second SAB, she had prolonged vaginal bleeding that had lasted about 6 weeks after her misoprostol. At that time, they were like, this is a little odd, let's get an ultrasound. And they were concerned about a fundal uterine AVM. So they immediately ordered more imaging, confirmed that with CT, and she went on for IR embolization with gel foam. A week after her IR embolization, she continued to have bleeding. She went back to IR. They said, we want to try to get more of it. So they did a second IR embolization, and that did take care of things. She was told that she could have the potential for recurrent AVM, but it would likely be several years before that would happen. Because of this history with her embolization, she came into our office for preconceptual counseling, and we reviewed what that means. We talked about a accretive spectrum. She understood this. This was an IVF pregnancy, and she had had normal PGT as well as NIPT and normal fetal echoes for the babies. At some point early second trimester, she comes in at one of her office visits here with us. She complains of epistaxis, and the provider that was seeing her at the time was very astute and suggested that with AVMs and epistaxis that she be considered to potentially have HHT, which is hereditary hemorrhagic telangiectasia. Next slide. She was actually referred on to genetics, like not our genetics, preconceptual genetics. She referred to adult genetics, and they did the lab work and actually did confirm that she did have HHT. So part of HHT is you can get AVMs anywhere. So we just went on and ordered the workup for that while she was pregnant, which included an MRI of the brain and spine to look for cerebrovascular AVMs as well as spinal AVMs, as well as a maternal echocardiogram that can look for pulmonary AVM. That was very confusing to me, but it's a matter of if the beats through the echocardiogram, if the bubble doesn't, oh, it's with a bubble study. If the bubble doesn't return, then you know there's an AVM in there circulating. So it was for pulmonary AVM. In ultrasounds in pregnancy, the A had an anterior placenta, B had a posterior placenta, but there was never any concern for accreta or recurrent thoughts of recurrent AVM during her ultrasounds prenatally. Next slide. So she was admitted as planned for those next few days, stayed till 34 weeks. She went down for a planned cesarean section because of her prior history of AVM, and she had twins. That was her choice to have a primary section. Next slide. So she has a low transverse section. A comes out, does fine. B comes out, does fine. The placentas are removed. They specifically noted in the op note that the uterus was exteriorized. They didn't notice any evidence of AVM on the outside or in the portions of the uterine interior. They made sure to evacuate all clots, everything extensively. And then when they went to do the uterus repair, they noted profound uterine atony. So again, they start with all the basics. She's already getting her Pitocin. They add in the misoprostol, Hemabate, and TXA. They're having, obviously they're around 2,000 of EBL at the time that they're giving all that. And by the end of the procedure, they felt like it was all related to atony and that they had achieved hemostasis otherwise. And they felt the tone was better, but when they went at the end of the procedure, when she's closed and they're evacuating clots from the vagina, they noted that there were a little more clots than expected, but the tone felt pretty good. She was a thin patient, so they felt like tone was pretty good compared to what it had felt like in the case. So they moved out of the OR and into recovery. Next slide. So she moves into the recovery room. They're thinking everything looks great. And then the nurse calls the team back and says there's something wrong. The patient's eyes rolled back in her head. I saw a visible color change. Her blood pressure had plummeted to 40 systolic. She was literally lactosing, bleeding from her vagina. And then they were able to evacuate more large clots. And now the tone was again poor. At this point, the EBL was over 3 liters. And this is where I think it's super important that the team, knowing that she had this history of AVMs, chooses to place a Bakary balloon to have more tamponade and put 500 cc's in, which is the max, so that it would be a lot of pressure. Anesthesia is still close by. They call them in, they get an A line, they start immediate fluids and initiate the massive transfusion protocol. And again, knowing that she had had this history, our was consulted, and actually they had called our earlier prior to the section and just said, hey, listen, we have this lady who's getting this case, who's getting a section today. She's had this case. We don't expect anything, but we just want you all to be aware so that if anything happens, you know that she may come down. So they called IR and they said, hey, we need you. And IR was ready. Next slide. So she goes through 3 units of red cells, 3 units of FFP, a unit of platelets and cryo, and then some albumin as well. During that process of getting the units and still working on tone and getting her Bakary in, she is in significant pain, which ultimately requires sedation and intubation. She is eventually stabilized, goes down to IR for her uterine artery embolization, loses a total of 3,700, and then goes to the trauma ICU for hemorrhagic shock post-IR. Next slide. So, like a lot of times in a hemorrhage, labs become very important. And in this situation, they didn't really, they weren't necessarily pertinent to how products were replaced because everything happened so rapidly. And then once it was under control, it was there. Like Daniel's last case with DIC probably has more pertinence as you're following those labs. In this situation, I just put in her before and afters and just some things to point out that the fibrinogen never really significantly dropped, which is why she probably did well with her 1 unit of cryo. And then her TEG was also within normal limits, which is during the whole active bleed, and which is how they also knew they were probably stable for no further replacement than what they had already given. On post-op day 1, her H&H remained stable, and so did her fibrinogen. Next slide. So she, of course, her indicators are hemorrhagic shock as well as ventilation. Those are her 2 primary indicators. Next slide. Not the greatest picture, but I also like this. We keep this in our ORs. It's huge. This doesn't really do it justice to see it. And this actually, it's kind of cut off too. My apologies. But we have a huge, it's like a presentation poster, like if you were going to a meeting. Size poster in all of our ORs, which, you know, people that have been doing this for a while, you know, tend to know the medications that can be given and the steps that you should go through. But I think it's just good reminders to have there. It's great for our learners when we're in a learning setting. And honestly, when you're in something that's happening, sometimes you forget, like, you know, how often you can give things, or, you know, what you need, where, like a double check of to make sure you've done everything in the step above. So having these in the OR is very helpful for the whole team, providers, nurses, anesthesia, everybody, to make sure that we're not missing anything that we could be doing to optimize outcomes. Next slide. So, you know, takeaways to some extent are, I put in the knowledge of her history. So it is so important to take a detailed history and to not dismiss anything that patients say. You know, sometimes people tell us they have clotting disorders or bleeding disorders or whatever, and they haven't gone to a specialist. And so do we take it that serious? Oh, I also meant to say that the von Willebrand's lab that came back during the hospitalization, which it took like several days, I think she was discharged before they even came back, actually did come back normal. So we don't know if those labs that were abnormal prior to her admission were something was wrong, something happened with the lab. We don't know. Nonetheless, the lab prior to her getting delivered were actually normal. But knowledge of the history is so important. Like, if we weren't thinking about von Willebrand's, then, you know, we could have, I mean, sorry, if we weren't, oh, that was for the other case. These guys, I'm so sorry. I got sidetracked because I was talking about history. History was very important in both of these cases. This time, in this case, it was important because the history of that AVM allowed our provider to know that they wanted to use a Valkyrie. We've primarily been using Jada. It's not that there's an absolute preference, but in this situation, she chose to use a Valkyrie because she knew that she had if there was an AVM that was causing all that bleeding, she wanted the most pressure she could get, and so she felt like Valkyrie was was superior in that situation than a Jada. So knowing the history of the patient in both of our cases today, or the cases that I presented, was extremely important. The other thing is it is critical to be prepared, and that's from the nursing side, the physician side, and to have these protocols in place, because protocols truly do save lives. So when we have a big postpartum hemorrhage, and then if you're ready with meds, and if you have massive transfusion protocol that you can just call down to the blood bank and say send it up, and everything comes up seamlessly, that's how people survive when these bad situations happen. And then again, just like the last case, see, overlap for both. Collaboration is so important. Having anesthesia immediately available to come put in an A line to run, you know, so we could run fast fluids and monitor her pressures is critical. And then knowing, you know, that communication with IR ahead of time so that the IR suite was available and that she could be stabilized and sent right down, and you didn't have to worry about, you know, where are they, or are they available? Is there? So they knew, and she went right away. And then of course the ICU care, critical care team, is always important to collaborate with them while they're in the ICU. So I think that's, yeah, I think that's probably the last slide. Yeah, and then Dr. Nelson added these slides. We had 2 cases of substance use disorder in our presentations today. So this is just a little slide about our team that we have here at UT. This is the flyer for the compassionate access, the CARES team, compassionate access to recovery support. And then do you want to say anything more about that?
I would just say that through this process, we've realized that there's so much more that goes into patients' care who have substance use disorder that we really have to wrap around the social support, the lactation consultant, the neonatal case manager, and it's been vitally important to the success of this clinic to have psychiatric mental health nurse practitioner available to assist these patients in medications adjustment and dosage adjustment and monitoring for superimposed peripartum mood disorders. That I feel like what's made it successful is this whole team of people who take care of these patients and participate in their care rather than just the sole standalone obstetric provider. And maybe one more slide, Tanika. And that's it. And we're happy to take any last minute questions. Sorry we ran over.
Does anyone have any questions for either Megan or Doctors Nelson and Wolf?
I might just put a little plug in for that last patient too. Like, she was a very anxious patient. I know we mentioned like debriefs for the team, but it's important to have debriefs with the patient. No doubt she will have some pregnancy trauma given her anxiety at baseline. So when he mentioned social work and like mental health, like, she will need some support for this pregnancy. So I think that's always important to remember too when we're talking about things and that have any sort of SMM involved. Like, how is the patient perceiving what happened, and try to debrief and go through things with them before they leave the hospital. And then follow them up as an outpatient as well, because the SMMs usually have something that's severe, and these patients are often taking that with them and not mentioning it to us because, we're all invested in the baby. So don't forget to ask about their mental health. Thank you, everybody, for coming.
Yes, thank you so much. And thank you all, Megan, Dr. Nelson, and Dr. Wolf for joining and presenting our cases. And I know that everyone really enjoyed them, especially hearing about the major OB committee, which I will say is such a well-oiled machine. Megan has worked so hard on that committee for so many years to develop it. And I think that the success that UT shows with their SMM cases is a reflection of that.
And also too, because the major OB has done so well, we now have a major GYN. I don't know exactly what they call it, but essentially a major GYN committee where they review like any GYN things that are happening. So it's really neat to see how it has evolved.
And so just a little reminder, we do have some upcoming SMM webinars. We are trying to do these quarterly, so we will have one in November of this year and then January of next year, and I will be announcing those dates as soon as I have them set. So if you have time, just take this post-event survey. Let us know what you thought about it, and if there are any cases that you all would like to see being reviewed that have an SMM indicator.